Hello. Good afternoon, students. Welcome to this session, which we are specifically taking for the FMGE students. Okay, so this is for FMGE Rapid Revision Series, where I will be yeah. So all of you, welcome to all the students, and yes, okay, so all of you can hear me, all of you can see me, it's loud and clear, and this is what we plan to do in this session is to discuss some of the most important MCQs likely for the upcoming FMG examination. Okay, generally at the FMG examination, OBGY, you can get up to 30 MCQs to 35 MCQs. Last year, December examination, I got a lot of phone calls from the student that almost 45 to 50 questions, sir, were from your lectures. So if you are lucky, even more questions can be expected from obs and gynae. Okay, so without wasting any further time, let's start on to the first question for the day, and the first question is LH peak precedes ovulation by. So we will not only be discussing these MCQs, we'll also be discussing many other MCQs also related to this topic. Okay, so this itself gives, even the question gives you one answer, because it's been asked that ovulation takes place because of surge of which hormone. So the answer is LH. Okay, even this simple basic MCQ, that ovulation happens because of the surge of LH hormone, has been asked to the students in the entrance examination. Okay, now please pay attention. Please pay attention. It's very important, and I always tell the students that please read the question correctly before answering. I'll be giving you a simple figure. I'll be giving you a simple figure which will help you remember this topic. Okay, so remember that from entire onset to ovulation, entire onset to ovulation is going to be 36 hours. So that is the first question. Okay, it's understood to all of you. So onset to ovulation is going to be 36 hours, and this is the simple graph which you remember. Okay, onset to reach the peak, onset to reach the peak, if this is the peak, it is going to take 24 hours, and after the peak is reached in another 12 hours, the ovulation will take place. Is understood to all of you? So all of you know this, that all of you know that now 24 plus 12 is 36. So I always tell the students, please read the question correctly before answering. It's such a simple figure, such one figure, and three different MCQs can be coming from this topic. So the question over here, if they ask you onset to ovulation, what will be the time? 36 hours. Onset to reach the peak, what will be the time? 24 hours. And after the peak is reached, when will the ovulation take place? 12 hours. Okay, so that is the answer to this very basic and very simple MCQ. Please keep this in mind. Okay. Okay, so the answer to this MCQ is 12 hours, because the question is LH peak. When will the peak precede ovulation? So this has been asked, that indirectly the question asked to is that after the peak, when will the ovulation take place? The answer is 12 hours. I repeat, if the question was onset to ovulation, okay, LH surge onset, okay, LH surge onset to ovulation is how much time? Then all of us know 36 hours will be the time. Is understood to all of you? So please read the question correctly before answering and mark it accordingly as per your this one. Okay, as per the this. And if they ask you onset to ovulation this, and after peak, 12 hours is the answer. And let's just, because so three MCQs have been discussed in this, and very important rule which I would like to tell you is, remember this, that only if the female ovulates. Okay, so ovulation, corpus luteum, progesterone. Okay, so only if the female ovulates, then the corpus luteum is formed, and then the progesterone comes into the picture. Okay, so progesterone is the second hero or second heroine whose entry into the movie is only after interval, like after ovulation. So why this rule is important is because ovulation, corpus luteum, progesterone. So no ovulation, no corpus luteum, no progesterone. So in conditions where ovulation does not take place, progesterone would be absent or progesterone would be very, very low levels. Okay, example of which is PCOS. So again, this MCQ was asked in the previous exams, that PCOS, which hormone is deficient or which hormone is less? Sir, because PCOS patients will not be ovulating, so progesterone will be lesser, and progesterone comes only after corpus luteum. So I repeat, ovulation happens, then only the corpus luteum is formed, and then the progesterone enters into the picture. So this was again one of the MCQ are that which is the dominant hormone in the luteal phase of the cycle. Okay, which is a dominant hormone in the luteal phase of the cycle, and the answer to this MCQ is progesterone. That's why progesterone is the dominant hormone in the luteal phase. Okay, luteal phase is the phase of the cycle which is there after ovulation. Okay, so progesterone is the dominant hormone in the luteal phase of the cycle. So this is again a very, very important MCQ based on which question would be coming to all of you. So all these are important questions, please keep in mind, and the answer to this MCQ is 12 hours because it is LH peak. Okay, entire onset to ovulation 36 hours. Please keep these points in mind. Okay, moving on to the next question, very, very important question. The best time to sample LH-FSH in a patient of PCOS is, okay, that when will I measure the LH and FSH levels in any patient? Now please understand this, the question is about PCOS patients, but any patient if they ask you, okay, any patient if they ask you whether PCOS or not, okay, whether PCOS or not, any patient if I want to measure FSH LH levels, anybody? So please keep this point in mind. Those who want to become gynecologists, remember, lifelong, and those who don't want to become gynecologist till your entrance exam is over, please remember that FSH and LH should always be measured on day 2 or day 3 of the cycle. It's a very, very important MCQ, and definitely questions are going to be asked to you on this, and this question is very important. Okay, now please pay attention, couple of points, we'll come back to the question in some time, but couple of points. Okay, that remember this lifelong, that whenever the menses start, okay, this is a very common mistake students do not know, that whenever the menses start, that is day 1. Okay, so what am I saying is that if today the patient's menses start, then tomorrow or day after tomorrow, please call her to the laboratory and collect her blood sample for FSH and LH. Is understood to all of you? FSH should be done on day 2 or day 3 of the cycle. So remember, and day 3 of the cycle means on which day of the cycle? Day 2, day 3, day 14, 16, 18, all these are the options. Day 2 to day 3 is the answer. And remember, when the menses start, the day the menses start, that is considered as day 1. Okay, that is considered as day 1. Please keep that point in mind. Now, two three more points about this. So FSH LH should always be, the patient bleeds for 4-5 days, so it is not 1 to 2 days after the menses are over, it's on day 2 only. If today the menses start, on day 2, okay, on day 2 or day 3 we have to measure the FSH and LH ratio. Now please pay attention, normal condition, normal patients, very, very important, FSH to LH ratio is 2:1. This is normal. This again could be asked to you. So please be very clear that we are not only discussing these MCQs, we are discussing all the other MCQs which could be asked to you in and around this. Okay, so first, when do you do FSH LH? Day 2, day 3. What is the normal ratio? So 2:1 is the normal ratio. And anybody, what happens to the ratio? Anybody, can you type in the chat box and tell me what happens to the ratio in PCOS? Yes, in PCOS the ratio will become inverted or ulta. In PCOS the ratio could be 1:2 or even 1:3 or even 1:4. Okay, why? Now why this happens also, please keep in mind. Okay, so 1:2 or 1:3 or 1:4, this is in PCOS. Very, very simple, very, very basic MCQ. Inversion of FSH to LH ratio seen in which condition? 1, 2, 3, 4. Please mark PCOS as the answer. Okay, I hope it is crystal clear. Okay, so why does this happen is, remember that in PCOS, yes, correct, yes, yes, Vishwaraj, very good, beta, Vishwaraj Singh, yes. Okay, so please pay attention that why this happens is that in PCOS, the FSH could be normal or slightly lesser, but it could also be normal. Okay, but LH is definitely going to be on the higher side. Remember these words about PCOS, that sir, in PCOS we are going to get persistently elevated LH, okay, throughout the cycle. It's persistently or a tonically elevated LH levels are going to be seen. So LH is definitely going to be higher in a patient of PCOS. It's a very important point. Okay, just by the way, the very high level PG level thing, but just to show you, if you see at the graph, that if this is the if this is the if this is the if these are the LH levels, if this is the LH levels, and these are the days of the cycle, day 2, day 3, day 4, day 8, day 10, day 12, day like this, day 14, day till day 28, then please understand LH level is going to happen like this. Okay, LH will go like this. Okay, all of you know that the highest will be at around day, this is the LH levels. Okay, this graph I'm drawing of the LH levels. Okay, day 10, day 12, the LH would be there, and then you know that roughly the ovulation takes place on the 14th day. Okay, if it's a regular 28-day cycle, in a regular 28-day cycle, the ovulation will take place on the 14th day. If it's a regular 28-day cycle, remember that. Okay, so this is a normal patient. This graph what I have drawn, this graph is normal. But in PCOS, what will happen? This will be the LH level throughout the cycle. LH will be on the higher side. This will be the LH level. Okay, so you can see over that on day 2, day 3, when I will see this LH we will get is at a higher levels. Okay, yes. Okay, so LH will be higher. So this is very important. I repeat all this. So day 2 or day 3, it's a very important MCQ, definitely coming in the upcoming exams. Day 2, day 3, and when the menses start, that is day 1. That is the time when you measure a patient of PCOS levels FSHL. And as I repeat, even if PCOS is mentioned or not, okay, only FSH. Okay, please understand, only FSH is a test done. It is as a marker for ovarian reserve. Okay, as a marker for ovarian reserve. This test done is, one of the test is FSH, one of the test. Okay, it's a marker for ovarian reserve. Ovarian reserve simply means your bank balance. What is the capacity of the ovary to produce eggs? So if the FSH is normal, then there are many more eggs left in the patient's body. It's master and servant. Okay, ovary is your servant and FSH comes from the master, pituitary. Yes or no? So if the ovarian reserve or the bank balance is becoming less, then FSH would be increasing higher, because master has to shout more loudly and tell, Baba, kaam karo, work. Okay, so FSH, more signals will be sent to the ovary. So just by the way, this FSH is also done on day 2 only, day 2 or day 3. Okay, is it understood? So whether they mention it or not, whether they mention PCOS or not, whenever I want to, either we measure only FSH as a marker for ovarian reserve, or we do FSH to LH ratio, then I measure both. Both of the tests are always done on day 2 or day 3. It's understood to all of you. So whether they mention PCOS or not, remember FSH always day 2, day 3. So many MCQs, FSH on day 2, day 3. FSH is one of the marker for ovarian reserve. Ovarian reserve means capacity of the ovary to produce eggs. This is an MCQ. And normal ratio 2:1, this is an MCQ, and this ratio becomes inverted, again an MCQ. So 5-6 MCQs already discussed with this, and LH is going to be persistently elevated in patients of PCOS. So keep all these points in mind, because all these are the important MCQs which could be asked to you in the entrance exams. Okay, moving on to the next MCQ. Total LNG content in LNG IUS is. Okay, so anybody, total LNG content in the LNG IUS is. Now before we proceed further, 2-3 things. Okay, LNG IUS, what is it? It is called LNG IUS because it's called as an intrauterine system. Okay, intrauterine system. Okay, intrauterine system, but it has got many other names. One name is called, it is also called as LNG intrauterine device. Okay, and very popularly it is called as Mirena. Mirena is a brand name. Mirena is a brand name. Okay, beta Narasimha Naidu, you made a slight mistake, beta, and even your Selvin Cham, beta, Selvin Cham also, beta, you made a mistake, beta. Why? Because please, this is a very tricky MCQ. Don't, please pay careful attention. Okay, so please read. There are 2 separate MCQs. Why I have selected this MCQ? Because it's a tricky MCQ and many students likely to make mistake. Okay, total LNG. Okay, total content of LNG has been asked to you. Okay, so first remember the different names. Remember the different names. It is LNG intrauterine system, or also called as LNG IUD, or also called as Mirena, also called as LNG 20. Why is it called 20? Because every day 20 microgram per day is released, but the total LNG is 50 milligram, 52 milligram. That is, please by heart these numbers. Okay, and very, very important point, this is a method of birth control effective for 5 years, and it's one of the highly effective method of birth control. It's one of the best methods of birth control. Why? Because it has got very, very low failure rate. The failure rate is only 0.09 to be precise, or even if you remember 0.1% is absolutely fine. Okay, so all these are the important MCQs which could be asked to you in this. I'll come back to the question in a minute, but please clap if you feel happy. First of all, Mirena is same as LNG intrauterine device, is same as LNG 20 and also Levonova. Why is it called LNG? Because sir, it contains levonorgestrel. Total, how much is the LNG, all of you? Yes, 52 milligram, and 20 microgram per day is released into the uterine cavity, and the effectiveness, it is valid for 5 years, and the failure rate, please remember, only 0.09 to maximum 0.1%. Also, if you remember, absolutely fine. Okay, so Mirena totally is 52 milligrams of LNG and 20 microgram per day is released into the cavity. Is understood to all of you? Many students made a mistake in this question because they did not read the question. I repeat, yes, the question, if in case the MCQ is that per day, okay, if the question is that LNG released per day, okay, if the question asks is per day, how much is released, then all of us know it is 20 microgram, okay, 20 microgram per day is released, okay, is this understood to all of you? So 20 microgram is every day, okay, every day, but the total content is 52 milligrams, okay, so do not make a mistake. I will also point out the points, okay, that also keep all these points in mind, okay, that this is microgram and this is milligram in this also. So many students made a mistake with this because they confused between microgram and milligram, okay, so please don't make a mistake in this. And now clap if you feel happy for the first time ever, or many of you may be seeing it for the first time ever. And again, each and every line, okay, so see this, there are 5 MCQs on this slide, one slide but 5 MCQ. This is an MCQ, this is an MCQ, this is an MCQ, this is an MCQ, this is an MCQ. So every line, so many 5 MCQs have been taught to you based on just this one slide, okay. And all of you, please pay attention. Yes, this is how a image based question also we are discussing, that this is how a Mirena would look like, okay. So it is completely white in color, it will be a white in color device. If you get this image, very likely for the upcoming exam, it's a totally white color device. This is a hormone barrel will be there, hormone cylinder, and this is releasing the hormone. Which hormone? All of us, LNG, and there are threads which are there with which we can remove it afterwards, okay. So please keep this in mind, okay. Obviously remember this, that when you see, okay, obviously that this is not a copper T. Don't get confused, because in a copper T what will happen is that, yes, in a copper T there will be a brown color copper wire, okay. All of you please be aware, if it's a copper T, then there will be a brown color wire like this, okay. There will be a brown color copper wire, copper will be wound around it. Copper is either wound around the stem, or copper is there over here, over here. So this is not there over here, yes or no, this is not there. So do not confuse it with a copper T, and all of you will know it. So this is not a copper T, this is your Mirena. Is understood to all of you? This is a Mirena, because white color device, completely white, and hormone cylinder. And what is the hormone containing? LNG. I repeat, how much LNG? How much LNG? Yeah, thank you. Okay, kid, thank you. Okay, how much LNG? 52 milligram LNG total. Okay, and 20 microgram per day. And very, very important, please pay attention. This also is asked to you. That today Mirena is used more and more for its non-contraceptive benefit. Even though it is a method of birth control, Mirena or LNG 20 has got lots and lots of non-contraceptive benefits. Anybody, what are the non-contraceptive benefits of Mirena? Okay, this again is a very, very important MCQ for all of you. Anybody, what will it do? So please pay attention. What it does is that when you insert Mirena in somebody's uterus, it is going to continuously release progesterone. Yes or no? Mirena is going to release progesterone. Yes or no? So when the Mirena is fitted inside the uterus, like this Mirena, it is going to continuously release progesterone, release progesterone. Yes or no? Release progesterone. So what will happen? Because of continuous progesterone, it basically leads to a state of progesterone induced amenorrhea. Very, very important concept. Please keep in mind that, sir, the menses of the patients will keep on becoming scanty, and then the menses will stop. That if a patient is bleeding for 4 5 days, she will be doing it for 3 days, then 2 days, then 1 day, then only spotting, and then the menses will stop. Okay, yes, very good. One of them, okay, Sumanti, yes, okay. So before that, okay, so menses will completely stop. So it leads to a state of, remember these words, it leads to a state of progesterone induced amenorrhea. So where all it can be used? Yes, it can be used for menorrhagia. Those patients who have heavy periods, menorrhagia or dysfunctional uterine bleeding, or even painful menses, dysmenorrhea. Okay, so all these are the benefits. Okay, menorrhagia, dysmenorrhea, then what else? Yes, very good, it is progesterone. So even the fibroid size, very good. Okay, somebody say, okay, fibroid size can get decreased. That is also agreed. Yes, the fibroid size can get decreased because of progesterone. And what else? Yes, endometriosis, it can be used. So all these are the various benefits of this Mirena, endometriosis. Okay, and what one more thing? Yes, because of continuous so it can be used in prevention and treatment of, yes beta, yes, correct. Okay, yes, Nikhil, correct. Okay, menorrhagia, dysmenorrhea. Okay, and also your endometrial hyperplasia. Yes, Ruben Raj, correct, Reggie. Okay, yes, correct, endometrial, I told you. Okay, endometrial hyperplasia, also it is going to decrease. And also treatment. Okay, it is for both, it is for prevention and treatment. And which cancer can become less? Anybody? Which cancer can become less? Even CA endometrium can become less episodes, because when we teach you actual CA, okay, CA endometrium also becomes lesser in Mirena. It protects against endometrial cancer. Okay, Mirena protects against endometrial cancer. So many benefits: menorrhagia, dysmenorrhea, endometriosis, adenomyosis, fibroids, endometrial hyperplasia, endometrial cancer. All these are the non-contraceptive benefits of this device called as Mirena, because it leads to a state of progesterone-induced amenorrhea. So patients' menses will stop. Okay, and don't worry about it. Please understand this, that this is just one point to clarify, that Indian mentality and mentality of ladies across the world is that, sir, menses I should get every month. Otherwise, inside the body or inside the uterus, some kachra will get accumulated. Sir, kachra jama ho jayega. So no, please understand one thing, that when you insert a Mirena and when the menses stop, it is nothing to worry at all. Why is it nothing to worry? Because it's a progesterone induced amenorrhea. Okay, so why is it nothing to worry? Please pay attention. It's a very, very important concept, that how does Mirena work is, all of you know that progesterone counteracts estrogen. Yes or no? Progesterone counteracts estrogen. So the lining will not grow only. Please pay attention. What is menses? What is menses is only if the lining grows. Yes or no? Only if the lining inside the uterus grows, then that lining comes out in the form of menses. Yes or no? Please pay attention. All of you look over here. Okay, so only if this menses, okay, is the menstrual lining, this is the endometrium. So only if the lining, okay, only if the lining grows, then that lining is shed off in the form of menses. Okay, then this menses. But what will happen if when the patient is on Mirena, that means when a Mirena has been inserted in the patient's uterus, it will not even allow the lining to grow. So lining will be very, very thin. Okay, please understand, the endometrium for a patient who is on Mirena will be very, very thin. Okay, very, very, very thin endometrium, because the endometrium does not grow only because of continuous progesterone. Because of continuous progesterone, the estrogen will not be able to act. It will block the action of estrogen, and the lining will not grow only. So common sense, if the lining will not grow only, what will come out? Nothing will come out. It's like a simple analogy I like to tell all my students, that only if the beard, okay, only if my beard is growing, then I shave. Okay, if the beard is not growing only, like tiger shroff, okay, tiger shroff, beard does not really shave. Okay, so beard grow ही नहीं होगा तो क्या shave करेंगे? Is understood? So similarly, sir, if the lining will not grow only, then lining will not come out only. Okay, so don't worry. because students get confused. Sir, if 2-3 years patient will not get menses, yes, don't worry, menses will become scanty, and then eventually, so first month less bleeding, second month still less bleeding, finally menses will stop. Okay, and then for 2-3 years patient will either not get completely menses or little spotting, only little spotting can happen, but that's fine, because those who have got menorrhagia, dysmenorrhea, they are fine with little bit bleeding. Okay, because the sir, please take care of my heavy periods. Okay, so this is how, remember that what does Mirena do? Sir, Mirena causes progesterone induced amenorrhea. Very high level point, very important point, that progesterone, because of continuous exposure, the lining will not grow, only lining does not grow. So there is no question, if the lining does not grow, there is no question of shedding off, so it leads to a state of amenorrhea, and this amenorrhea is not at all harmful for the patient. In fact, it is for prevention and treatment of endometrial hyperplasia and also prevention of C endometrium. So please keep all these points about Mirena in mind, because all these are the very important MCQs which could be asked to you. Okay, and I come back with the answer. 52 milligram is the total LNG content, and 20 microgram per day is. Yeah, beta, Rubin Raj, if I get time to permit, I'll discuss that. Beta, laparoscopy is done for lots of indications. Okay, laparoscopy is done to it can be for diagnostic as well as therapeutic. Okay, so laparoscopy, today we do laparoscopy for whatever can be done by opening up the abdomen, laparotomy, same thing can also be done today to laparoscopy. So today for hysterectomy, myomectomy, fibroid removal, uterus removal, all these operations, ectopic pregnancy, ruptured, and all these cases we do laparoscopy. Infertility workup, all these cases laparoscopy is done. Okay. Okay, is understood to all of you? Okay, yes. Now all of the following are very important. All are following actions of emergency contraception, except, okay, now when we use emergency contraception, please pay attention, the act of sex is already over. Okay, the act of sex is already over, तीर कमान से निकल चुका है. Okay, sperms have left the body. Okay, so what can emergency contraception do and what it cannot do? Okay, now please pay attention, this emergency contraception, they are also called as interceptives. Okay, what is the meaning of interceptives? That means their main action is to prevent the implantation, because the act of sex is already over, so sperms have left the body. Okay, so before that we should know, when do we give emergency contraception. Okay, so what are the indications for emergency contraception is, we should know is that emergency contraception, boyfriend girlfriend meet, they have no plan of having sex but they'll end up having sex. Okay, so basically it is unprotected intercourse. Okay, unprotected sex, that's the first thing. Second is after rape. Okay, if a rape victim comes to you, then immediately we need to give. And third is यू हैव यूज्ड अ कॉन्डम, लेकिन सेक्स के बाद पता चलता है कि अरे कॉन्डम में तो होल था, मतलब ऐसा कॉन्डम में पहले से होल नहीं होता है, बट कॉन्डम रप्चर्स और टेयर्स ड्यूरिंग इंटरकोर्स. ओके, सो कॉन्डम टेयर्स ड्यूरिंग एन इंटरकोर्स, then in this cases, then immediately emergency contraception should be offered to the patient. Is understood to all of you? Unplanned unprotected intercourse, rupture or tear in the condom at the time of sex and after rape. Okay, now please understand this, that this emergency contraception, how does it act? It can delay ovulation. It can delay ovulation. It may also prevent the union. It may also prevent the union, but the most important action is it makes the uterus unsuitable for implantation. So it will mainly prevent implantation. That is what it works. But now please tell me this, all of you also. Suppose if it's a very early pregnancy, can my emergency contraception also dislodge that early pregnancy? Yes or no? Yes or no? Yes or no? Yes, can emergency contraception also dislodge that early pregnancy? Can you please tell me yes or no? So please pay attention that the emergency contraception, if it is a pregnancy, if once you are pregnant, okay, you means if the patient is pregnant, lifelong, there are only two options. What are the two options if already the pregnancy is confirmed? Either you continue the pregnancy or you go in for MTP, which is a totally separate discussion. Okay, is understood to all of you? Yes. So please understand this, that the emergency contraception, they are not abortifacient. I repeat, they are not abortifacients. Okay, they are not abortifacients, and therefore it cannot interrupt the early pregnancy. However early the pregnancy may be, if the patient is pregnant and she does not want that pregnancy, then you have to go in compulsory for MTP. Is understood to all of you? Yes. So now all of us know this. Now all of you know this. That now what is the answer to this MCQ? Yes. That please pay attention. That the answer to this MCQ is that, sir, it could be yes. It can delay ovulation. It can inhibit fertilization, and preventing implantation is the most important action. Answer is option number 4. It cannot interrupt a early pregnancy. However early the pregnancy may be. Okay, to interrupt a pregnancy, we read MTP will have to be done. Okay, and therefore this is preventing implantation. Therefore they are called as interceptives. Okay. Okay, emergency contraception are also called as interceptives. Okay, interceptives. Okay, now in this remember that we get hormonal as well as mechanical. Okay, we get hormonal as well as mechanical for my emergency contraception. Okay, hormonal and mechanical is your IUCD, intrauterine contraceptive device. Okay, and hormonal, remember one which is very popular, I'm sure all of you are knowing, ipill. Okay, ipill is a brand name. Okay, ipill is a brand name, but IPL will not be asked to you because IPL is a brand name. But what does IPL contain? Anybody? What does IPL contain? Sir, IPL contain. Have you seen? It's a single tablet. IPL is only a single tablet of 1.5 milligram levonorgestrel. Okay, so please keep this point in mind. That what is used for emergency contraception? What is the most popular method? LNG. This has been asked to you, that which is the progesterone of choice. This is one of the most commonly used method of emergency contraception. Single tablet. Okay, and what is the emergency window? Emergency window is 72 hours. Okay, that means within 72 hours, in less than 72 hours. Okay, what is the meaning of emergency window by which this emergency contraception can act? Okay, so the ipill, I repeat, is a brand name, will not be asked to you, but the single tablet, single dose of 1.5 milligram levonorgestrel will be is to be taken as early as possible. Okay, as early as possible within 72 hours. Okay, obviously as early as possible the patient has to take it. Okay, but remember within 72 hours. Okay, is it understood to all of you? Within 72 hours. So this also could be asked to you, that what is the emergency window for your hormonal method LNG? It is 72 hours. And your mechanical IUCD advantage is it gives you 2 days extra. Here the emergency window is 5 days. Okay, so up to 5 days. Okay, so if they tell you that the patient presents to you on the 4th or the 5th day, then IUCD may be inserted. Okay, IUCD may be inserted up to 5 days. And why this is important 5 days is, please pay attention, because a very important MCQ. When does the implantation take place? Implantation takes place on the 6th day following fertilization. Okay, because implantation will take place on the 6th day following fertilization. Okay, so therefore it is very important that this emergency contraception will be effective mainly only up to 5 days. Okay, is understood to all of you? Emergency contraception will be effective mainly only up to 5 days, because then the 6th day the implantation will take place. I hope this is absolutely crystal clear to all of you. So we are discussing when. So we have discussed entirely how do the emergency contraception act, when do we give it, and what are all the mechanism of action of emergency contraception, except. Okay, so this is the answer, that sir, it cannot interrupt a early pregnancy, all except interrupting a early pregnancy, interrupting a early pregnancy. Okay, this is the answer to this very. Okay, yeah, Rupam. Okay, yeah. So please pay attention. Yeah, if the time permits, I will definitely discuss that also, beta, about the MTP dose and all that. It's a totally separate topic of discussion. Now moving on to the next question. Again, the very important MCQ. The commonest cause of primary amenorrhea is. Okay, so primary amenorrhea means the patient has never got her menses till now. Okay, never got her menses till now. Okay, that is your primary amenorrhea. Okay, now, but never got her menses till what age? Okay, so please understand 14 is also correct and 16 is also correct. Okay, 14 and 16 both will not be in your option. Okay, please keep in mind that for females it is thelarchy, pubarchy, menarche. Breast development starts, then axillary pubic hair starts, then the menses start. Okay, so while the yes, very good, your answer, all of you correct, all of you very very okay. So while all of you are correct, your answers are correct. Okay, so if by the age of 14 years you see the female and there is no axillary hair, no pubic hair, no breast development, then even at the age of 14 years you can label her as primary amenorrhea. But in case if the breast has started to develop, axillary pubic hair has also started to develop, okay, then we can wait. Okay, we can wait. Okay, menses will come like Rakhi. Okay, Karan Arjun आएंगे, Karan Arjun आएंगे, कब तक Karan Arjun आएंगे? Okay, so that time then we can wait for the menses to start. Okay, so then you wait till 16 years of age, and if still the menses do not start, then you label the patient as primary amenorrhea. Okay, this is very very important and very good. Ovarian dysgenesis, also called as Turner syndrome. Okay, also called as Turner syndrome, is the most common cause of primary amenorrhea. Okay, ovarian dysgenesis or gonadal dysgenesis or Turner syndrome 45XO. Okay, so all these are the important MCQs. This is the most common cause of primary amenorrhea. Okay, and in this slide itself, okay, this Mullerian Genesis or also called as RMKH. Okay, also called as Rocket. I tell you the full form: Rokitansky, Mayer, Kirschner, Hauser. Okay, Rokitansky, Mayer, Kirschner, Hauser. Okay, this is the RMK syndrome, Rokitansky, Mayer, Kirschner, Hauser. Okay, okay, this is the second most common cause of primary amenorrhea, second most common cause. And this androgen insensitivity syndrome, also called as testicular feminizing syndrome. Okay, it's a very very important topic. This is the third most common cause. So I'm not only teaching you the most common cause, I'm teaching you the second most common cause also, I'm teaching you the third most common cause also. So please keep all these points in mind when you go for the entrance exam, because all this could be asked to you. Okay, all this could be asked to you. I repeat the answer over here. The commonest cause pucha hai, answer is ovarian dysgenesis, also called as your Turner syndrome, depending on what is in the option. Okay, and your RMKH syndrome is the second most common cause, okay, of primary amenorrhea. And androgen insensitivity, also called as testicular feminizing syndrome, that is the third most common cause. Okay, is it understood to all of you? Third most common cause. Now very very quickly, please keep in mind, I'll show you one very important table which can help you solve many many MCQs in the future. Please understand this, that Turner's syndrome, the point to be kept in mind is that the uterus is present. Okay, even though the ovaries, the reason being why I'm telling you so much emphasis is that this is a very important MCQ. Okay, that in Turner's syndrome, the uterus is underdeveloped, hypoplastic, chin to rudimentary. Okay, okay, the Turner syndrome, the uterus is rudimentary, but it is not absent uterus, a hypoplastic or a rudimentary uterus, but yes, the uterus is present, but the ovaries are not functioning. Yes or no? Streak ovaries, you know that. Okay, ovaries, so o it means ov is the ovary. Okay, yes or no? All of you know, that's the thing. Ovarian dysgenesis, yes or no? That is the this ovarian dysgenesis. So ovary is not going to function. Okay, ovarian dysgenesis. Okay, and in RMKH syndrome, the uterus is absent, but the ovaries are perfectly normal structurally and functionally. So clap if you feel happy, that both of these are technically exactly opposite. The both of these are technically opposite, that here the uterus is absent, but the ovary is perfectly normal, but the uterus is absent. And here exactly opposite is there, that the ovary is absent but the uterus is present. Okay, present small but yes present. Okay, Is understood to all of you? So please appreciate this, all of you, please appreciate this, that the okay, please appreciate this, that both of them are technically opposite. Okay, both of these are opposite of each other. If you see why opposite, I'm saying that here, sir, the ovary is perfectly normal, but here the ovary is absent, and but here the uterus is absent, but here the uterus is present. Yes, okay, uterus is underdeveloped, small, rudimentary, but the uterus is not, it's not absent uterus. Okay, Turner syndrome, uterus is present. Please, very very important take home message. Okay, and in androgen insensitivity syndrome, also called as testicular feminism syndrome, here also the uterus is absent. Okay, so the very very important point to be kept in mind, but here the gonad presents are testes. So this you have to listen to the complete class, it's a very important class. So this one table can help you solve many many MCQs in the future. Okay, many MCQs can come based on this, just this one table can help you solve many MCQs. Okay, moving on to the next question, and that is Fothergill's repairs. Now what is the surgery associated with all of the following complications except anybody? So what are the complications of Fothergill, and where do you do this Fothergill's operation? Okay, so Fothergill's is one of the surgery for prolapse uterus. Okay, and which patients also, I'll tell you which patients you do and why it is no longer popular. Okay, okay, so please pay attention. Anybody, what is the main step? Okay, so Fothergill operation is also called as, anybody, what is the another name for Fothergill operation? Another name for Fothergill operation is your Manchester operation. Okay, Fothergill operation is also called as Manchester operation. Okay, Fothergill operation is also called as Manchester operation. Now the main step in this Fothergill, please understand, it was done in the past, it was done for young patients. Please understand, it's one of the surgery for young patients with prolapse. Okay, and the main step, because we wanted to preserve the uterus, of the patient. Okay, so it was done for the young patients of prolapse. The main step of this operation is cervical amputation. Okay, chop off the cervix, cervical amputation. Okay, this is the main step. Please remember this, by heart this, it's a very very important MCQ. Cervical amputation. Okay, the main step is cervical amputation. So initially when they devised the operation, all of them was very very happy. They were very very happy that very good, all patients, let us do this operation only, let us do this operation only. Then they started realizing that when I chop off the cervix, when we chop off the cervix, the remaining part of the cervix either becomes too tight or too loose. So after cervical amputation, two things can happen. Okay, either there could be tight cervical stenosis. Okay, cervical stenosis can happen because cervix will become tightly closed because of fibrosis. So because, and cervical mucus goes away, so patient started becoming infertile. Okay, cervical factor infertility, tight cervical stenosis. Okay, or cervix became too loose, giving rise to, yes, cervical incompetence. Okay, very very important. And if there is cervical incompetence, anybody, if there is cervical incompetence, then anybody, when will the abortion take place? Cervical incompetence always leads to repeated second trimester abortion, always. Okay, remember this, it's a very important, you can come back to listen to my actual entire class on abortion and miscarriages. It's cervical incompetence always will give rise to repeated second trimester abortion and never in the first trimester. Okay, okay, so cervical incompetence would give rise to second trimester abortion, or then there can also be preterm labor. Yes, it could be preterm labor. Okay, so now all of you know, that what is the answer to this. Okay, so there can be hemorrhage because of this Fothergill operation, repeated second trimester abortion because of this cervical incompetence, preterm labor or cervical stenosis, and infertility. So infertility can also happen, okay, and there could also be cervical dystocia. What is dystocia? Anybody, what is cervical dystocia? That, what is cervical dystocia? Yes, anybody? Cervical dystocia. Okay, so now all of you know. Now if we go back to the MCQ, now all of you know that what is the answer to this very very important MCQ. Yes, let's say the answer to this MCQ is all except first trimester abortion. Okay, the causes of abortion in the first trimester mainly are chromosomal and genetic. Okay, Fothergill operation will always give rise to cervical incompetence, and cervical incompetence may give rise to cervical incompetence, and cervical incompetence will give rise to repeated second trimester abortion. Okay, painless. Most of the time it's completely painless. Okay, or a pain of very short duration. It's a painless second trimester miscarriage or mid trimester abortion. That's a typical, very important point. Okay, so preterm labor can happen, infertility, and therefore remember that nowadays this Fothergill operation is almost never done. Okay, the Fothergill operation is almost never done. Okay, now anybody, what is this cervical dystocia? Cervical dystocia means that the uterus is contracting. Okay, uterus is contracting, but the cervix fails to dilate during labor. Okay, it's a condition which you encounter during labor. Okay, because many students do not know this word even after the internship is over. That's what is cervical dystocia. So I repeat, it's a condition which you encounter during NPOL, non-progress of labor. I repeat, cervical dystocia would lead to non-progress of labor, and then we might have to go and do LSCS most of the time. Cesarean section is done. I repeat, what is cervical dystocia? Sir, in spite of adequate uterine contraction, the cervix is not dilating. Is understood? That also can happen. So option 2, 3, 4, all are complications of Fothergill except option number 1 is the answer. Okay, first is the answer. It will not cause first trimester abortion, it will cause abortion in the second trimester. So this is understood to all of you. Cervical dystocia, preterm labor, infertility, and mainly cervical incompetence. So all these are complications of Fothergill operation. Okay, very important. So this is very rarely done. This operation, because of so many complications, this Fothergill operation is very rarely or almost never done. Okay, this Fothergill operation is almost never done. Okay, so initially it was thought that we will do it for a young patient to preserve the uterus, but then because of so many complications, the Fothergill operation is almost rarely done or almost never done nowadays. It is not very popular and not preferred operation because of it lots of complication. Okay, moving on to one of the obstetric MCQ. Triple marker test includes what? Again, this is a very important MCQ which came and many students made a mistake. First of all, to be kept in mind is what is a triple marker test. Okay, triple marker test. Okay, triple marker test is a screening test. It's a screening test. Okay, for what? It's a screening test for aneuploidy and specifically trisomy 21. It's one of the screening tests for Down syndrome. That if the baby has got Down syndrome, then we can screen the mother for it and we can come to know. Okay, so it's a triple marker test. Is a screening test. Okay, it is done. Now what is the sample? Okay, what is the sample for performing triple marker test? Okay, anybody what is the sample for triple marker test? Okay, yes, uh, many of you feel option 2, but I'll tell you what is the correct answer. Okay, so wherever I ask student all over India, generally wherever I travel, and when I ask the student that uh, what is the sample for performing triple marker test, they tell me, sir, I will do amniocentesis or amniocentesis or CVS. Wrong. Please understand, amnio, CVS, kachra, they are the confirmatory testing. No. Okay. Yes, amnio and CVS are all the confirmatory tests. For it is this triple marker test is a simple test done on maternal serum. Okay, maternal serum. This test is done. It's a simple test done on the maternal blood, on the mother's blood. This test is done, and the three markers are HCG, alpha fetoprotein, and unconjugated estriol. Please by heart this. It is not estradiol. Okay, it is E3. Okay. So option number 1, it is not HCG, PAPA, and estriol. It's not inhibin and all this stuff. Okay. So first, please by heart, this is a very important point. Please keep in mind. Okay, please keep in mind that when I do triple marker test, point number one, it is a screening test. That's a very important point. Please understand it's not a confirmatory test. Okay, it's a screening test. And what the sample for it? So it's done on maternal serum. Okay, maternal serum or mother's blood. And the three markers used are HCG, alpha fetoprotein, and unconjugated estriol, UE3. I repeat, it is estriol. Now, anybody, if in case the baby has Down syndrome, in case if the baby has Down syndrome, what will be the what will be the this? Okay, please pay attention. HCG arrow will be up. Okay, HCG will be higher than normal, and other two will be lesser than normal. Okay, please, very important. Please by heart this. Okay, very likely to be asked to you in the exam. Okay, now by the ways, values and the levels, nobody is going to ask you that values, even we do not know. Okay, it is higher than normal or lesser than normal. Okay, so what does this mean? What does this mean is, what does this mean is that okay, suppose the HCG comes out to be higher than normal, okay, and alpha fetoprotein is lesser than normal, and unconjugated estriol is lesser than normal. It is a doubt. Okay, please understand, it is not confirmatory. It is a doubt that the baby may have Down syndrome. It is a screening test. It's not a confirmatory test. The most important word on the board is that it is a screening test. Okay, the 100% confirmatory. Okay, so HCG arrow up, other two arrow down. Please keep this in mind. HCG alpha fetoprotein, unconjugated estriol. Please understand this, that anybody, which is the only test in the whole world which is a confirmatory test? Yes, karyotyping. Okay, you me have you may have got 46 chromosome. We want to detect baby with 47 chromosome. So karyotyping is 100% confirmatory. 100% confirmatory. If I want to do a test, then it has to be karyotyping only of the baby. Okay, so karyotyping is 100% confirmed. Okay, I hope this is absolutely crystal clear to all of you. Clap if you feel happy. Okay. So this is again a very important MCQ which could be asked to you in your entrance exam. Okay, in the upcoming FMG exam. Okay, one of the next question. The next question. Moving on. Osiander sign means. Now again, this is a sign which we see in early pregnancy. This is mug up. There is no explanation for this, but why I chose this MCQ? Because in this you may get around 4 or 5 MCQs correct. Okay, with this one MCQ and the 4 or 5 MCQs can be discussed. So Osiander sign is that in early pregnancy, if I do a PV examination, per vaginal examination, we can feel the uterine artery pulsations. So that is the answer. Pulsations in the lateral fornices. That is the Osiander sign. That is the Osiander sign. Okay, but we will also be discussing all the other things also. All the other things also we will be discussing. So anybody, what is bluish vaginal discoloration called as? Okay, so two names, please remember: Jacquemer sign, also called as Chadwick sign. Okay, so Jacquemer sign or Chadwick sign is option number 2. Bluish vaginal discoloration, remember both the names. Cervical softening is called as Goodell sign. Okay, very important. I'll tell you some more points about this to remember things about it. And on bimanual examination, approximation of the fingers, this is the Hagar sign. So I repeat, option number 1 is the answer. Pulsation in the lateral fornix, that is Osiander sign. Option number 2, Jacquemer or Chadwick sign. Option number 3, cervical softening Goodell sign. And bimanual examination, upper fingers, that is your Hagar sign. Okay, now please pay attention. If any, okay, if anybody is in the final year, they'll ask this also, that the non-pregnant cervix, please pay attention, non-pregnant gynac, because you will not get a chance to do a PV examination if you do not become a gynac. Okay, if you do not become a gynac, you will not get a chance to do a PV. So remember, this non-pregnant cervix feels like the tip of the nose. Okay, gynac patient, non-pregnant cervix feels like the tip of the nose, but the pregnant cervix is soft, and then it will feel like the lips. So all of you can palpate and check on yourself that for most of us, the lips will be very, very soft compared to tip of the nose. Yes or no? Tip of the nose is slightly firm and lips are slightly soft, because in pregnancy, a lot of vascular congestion and hormonal changes, so cervix becomes soft. Okay, but if you're very, very unlucky for you or unlucky for your partner, then it will be other way around. Okay, then it will be that the nose will be soft and the lips will be firm. Okay, so just the way to remember this, I like to tell all my students that if from firm to hard, if your lips are soft, it is good. Okay, if your lips are soft, it is good. Good is good L. Thoko tali, clap. Okay, so cervical softening, good L sign. So you'll remember me on the day of the examination when I tell the cervical softening. So if from year to year, if this conversion takes place from firm to soft, the lips are soft, it is good. Good is good L. Okay, that's the way you remember, good L sign. Okay, so lips are soft. I repeat, non-pregnant cervix feels like the tip of the nose, and pregnant cervix feels like the lips. Okay, so these are all the important MCQs I've tried to cover in 1 hour time maximum, whatever possible. And just before going, somebody asked me that, sir, if it is possible, then yes. Okay, so about the MTP and the dose and all that stuff. So just remember that when we give medicated abortion to the patient, initially on day 1, we are going to give mifepristone to the patient. Okay, mifepristone is generally given on day 1. Doses will not be asked to you, but just by the way, mifepristone is a single tablet of 200 milligram. Okay, mifepristone single dose 200 milligram is given to the patient on day 1. And mifepristone is what kind of a drug? It's an anti-progesterogenic drug. So pregnancy stops growing because progestation. Okay, this is your medical method of MTP in the first trimester. Okay, and after 48 hours, after 48 hours on day 3, okay, on day 3 we have to go for misoprostol. Again, this is an important MCQ. Misoprostol is what type of a drug? It's a PGE1. This also could be asked to you. So each and every line what I am saying is an important MCQ. Each and every word which I am saying could be asked to you. Okay, so mifepristone is an anti-progesterogenic drug. Day 1 given 200 milligram. Okay, 200 milligram. And misoprostol, remember, misoprostol, each tablet is 200 microgram. Okay, please don't get confused. I repeat, this is 200 milligram. Okay, this is 200 microgram. Okay, 200 microgram. And misoprostol generally 4 tablets. Okay, 4 tablets are used together vaginally. So the dose generally is 800 micrograms. Okay, 800 micrograms vaginally. Okay, vaginally. Orally can also be given, sublingually, buccally, various routes are available, but this is one of the regimens. You can also give it orally also. We can also give 400 microgram orally first. Okay, 400 microgram orally, and after 12 hours again repeat another 400 microgram if required. So orally also. Orally you don't give ek saath so much, so there can be nausea, vomiting, prostaglandin can cause even shivering. If you give sublingually, there can be shivering also. Okay, so all these points you please keep in mind. I repeat. So this is your recommended thing for your MTP, medical termination of pregnancy in the first trimester. Okay, mifepristone is given on day 1. Mifepristone is on day 1, 200 milligram. And okay, mifepristone 200 milligram on day 1, followed by 48 hours on day 3. Misoprostol, each tablet is 200 microgram. Okay, misoprostol, each tablet is 200 microgram. It basically, if you have seen the packet, it contains like this. There will be one single tablet and there will be 4 tablets, 1, 2, 3, 4. Okay, one single tablet of mifepristone is there and 4 tablets of misoprostol are there. Okay, misoprostol again is a PGE1 derivative. This is also asked to you, very important MCQ. And 800 microgram vaginally can be given. Okay, success rate, it's a very, very good thing. In actual practice, we get a success even up to 99% of the time. Okay, but the books mentioned roughly around say 96% or more. Okay, 96% or more is a success when you use for MTP. That means 96% or more, 96 to 99% of time patients will have a complete abortion and the whole pregnancy will be cleared. And that's why technically remember that after the tablets, please make sure, okay, generally on the 14th day we call the patient for follow-up, and we have to do ultrasonography to make sure the whole pregnancy is cleared and there are not any retained products of conception. Okay, so there should not be any retained products because medical abortion can also fail. Okay, 1 to 2% cases, 1 to 2% cases medical abortion can fail. Okay, so I hope this lecture has been helpful to all of you, and this is my batch which has already started. Dr. Punit 10 is the pro. I request all of you, please enroll. If this 1 hour class has been beneficial to you, then you can imagine how the entire class, when I'll be teaching you entire OBGY for your FMG or NEET PG also. This is the code. Please do not forget this, Dr. Punit 10. And depending on your requirement, Dr. Punit 10 is the code. You can take a 3 months, 6 months, 12 months or 1 year, 2 year subscription. So please use this. Please use code where I will be teaching the entire OBGY. Entire OBGY will be covered by me in utmost detail, enough for more than enough for any entrance examination, whether it's going to be NEET PG or your FMG. Every year I get so many phone calls and emails of the student that sir, each and every question in my paper were from your lectures. Okay, so Dr. Punit 10, please use this code to subscribe to either taking a 3 months, 6 months or 12 months or 2 years subscription depending on your requirement, and use this code so that you get a discount when you enroll in Unacademy through this promo code. Okay, and I wish all of you best of luck. I wish all of you will do very, very well. Paper in FMG OBGY is very, very straightforward, very, very standard, and it's going to be a easy cakewalk for all my students. And I wish all of you complete best of luck, and you will do very, very well in your exams. Okay, so best of luck. And at the last time again, so there are various batches coming up in the future also. Every month we are going to launch our cases or classes also. So these are classes and all the topmost teachers and educators are there which you can take. And it's not only FMG, NEET PG, even FMG batches also available. So Dr. Punit 10, please use this promo code to subscribe to the classes and buy the subscription of your NEET PG on Unacademy. Okay, and I wish all of you best of luck for your FMGE examination. Thank you. Bye bye. Best of luck to all the students.